Hello, my name is Kevin Hatton, and in this presentation I'm going to continue the discussion of acid-base balance, or as I sometimes like to say, this is a way to find the true meaning of all those numbers on the ABG. This is the second in a three-part series. The first presentation was really just the basics of acid-base balance and an orientation to my general approach to this complicated topic. The focus of that initial presentation was in differentiating between the primary acid-base abnormalities. For many people, this second presentation will be significantly more complicated. In it, I will describe my approach to determining whether there is appropriate compensation for primary and secondary acid-base abnormalities. This presentation will also deal with the anion gap and other complex issues in acid-base analysis. Because this second presentation can be a bit more challenging than the first, you may need to listen to it a few times to truly understand the topic. The third presentation will be a series of practice problems. In that presentation, I will demonstrate how I utilize the standard approach from the first two presentations to evaluate acid-base balance at the bedside. Overall, I hope these presentations will help you provide better care to your patients. My contact information is at the end of each presentation. Feel free to contact me with any questions or concerns about this or any of my presentations at any time. This slide is the obligatory conflict of interest disclosure. As you can read yourself, I have no conflicts to disclose related to this presentation. Okay, as a quick review, we have previously discussed a few things, including how to determine whether an acidosis or an alkalosis is present, how to determine whether the primary abnormality is related to a metabolic or respiratory problem, and finally, how to evaluate whether the primary abnormality is appropriately compensated by the body's homeostatic mechanisms. From these basic steps, we will launch into a more complicated discussion. If you have not watched my initial presentation, it may be prudent to do that now. Also, at any point, if you have questions or you are confused, you can always refer to the first video or email me, and that might help move you forward again. Let's start the presentation with the clinical case scenario that we have been using from the first video. Hopefully, this case represents a patient that you could see in practically any hospital, ICU, or emergency department. This patient, a 62-year-old male with chronic COPD, is admitted with an acute COPD exacerbation and lobar pneumonia. On his arrival, a room air ABG and a basic electrolyte panel are obtained. The results of these labs are shown on the slide. We have previously determined that this ABG suggests that the patient has a metabolic acidosis and that the acidosis is not appropriately compensated. But is that the end of the story? Is there more information to be gleaned from the ABG? For patients with incomplete compensation, it is possible to evaluate whether there are secondary or additional acid-base abnormalities. To define these abnormalities, remember that normal compensation is physiologically the opposite of the primary abnormality and that patients can be in one of three states. In the first state, compensated abnormalities, the ABG changes are exactly what is expected or what is calculated using the appropriate formula. In the second state, the overcompensated abnormalities, the ABG changes are greater than what is expected or what is calculated using the appropriate formula. In the third state, undercompensated abnormalities, the ABG changes are less than what is expected or what is calculated using the appropriate formula. Once you've defined the primary abnormality and the compensation state, you can then define the secondary abnormality. The table on this slide should help you in this determination. For example, if the primary abnormality is metabolic acidosis, as is described in the first row, overcompensation will result in a secondary respiratory alkalosis, whereas undercompensation will result in a respiratory acidosis. In other words, in a patient with primary metabolic acidosis, you would use Winter's formula to calculate the expected PCO2. We typically say that Winter's formula and all the other acid-base compensation formulas define whether or not the patient is compensated. However, what we are really doing is calculating what the compensating variable should ideally be in each different type of acid-base abnormality. To work through this a little, there are some practice problems coming up that hopefully will clarify this complicated step. Here's the first example of the presentation. I've named it example number 5, with the first 4 example problems located in the first presentation. I hope this does not cause too much confusion for you. In this example, the pH is 7.28, the CO2 is 60, the PO2 is 105, and the bicarb is 30. Using what we've learned from previous presentation, the primary abnormality is a respiratory acidosis because the pH is less than 7.40 and the CO2 is elevated. The formula to determine acute compensation in respiratory acidosis is 24 plus 0.1 times the difference between the PCO2 and 40. Using this formula, the expected bicarb concentration is 26. However, the real bicarb is 30. So in this way, there is overcompensation for the respiratory acidosis. The bicarb is not just increased from 24 to 26, but it has increased even more than that to 30. The patient, therefore, also has a metabolic alkalosis. The full interpretation of this ABG, then, would be a respiratory acidosis with a concomitant metabolic alkalosis. Let's head back to our clinical case. We've previously determined that the patient has a non-compensated metabolic acidosis. So, based on what we've learned and practiced already, what's his secondary abnormality? Again, pause the video, work the numbers, and unpause the video to see the answer of the question. Okay, if you worked out that he also has a respiratory acidosis, I agree with you. According to my calculations, his PCO2 should be 31. In this example, his PCO2 is greater than predicted, and he therefore also has a respiratory acidosis. Whew! For many students, that is a really hard step, and I'll admit it took me more years to learn than I really feel comfortable with. It also seems to be poorly taught in school. But it's now time to move on to anion gap analysis. If you don't feel entirely comfortable with the steps in the example cases we just went through, please don't move forward yet. Go back, listen to my previous explanations, and try to get a better understanding of these concepts before you move forward. Also, if you need to, reach out to me. I'm always happy to try and help you understand what is not working for you. High anion gap metabolic acidosis, sometimes called HAGMA, is caused by an accumulation of any of several organic acids in the blood that are not easily or normally measured in a routine electrolyte analysis. These organic acids can exist after ingestion of chemicals or medicines, or in homeostatic or other responses to certain clinical situations, as might occur with lactic acidosis or diabetic ketoacidosis. Personally, I learned the mnemonic mud piles to help me remember the most common causes of HAGMA. There are certainly other mnemonics. You may have learned a different one. They are all designed to help you remember the types of organic acids that might be causing the metabolic acidosis. I don't know that any one mnemonic is better than another, and I suggest you just go with what you've learned. For any patient with a metabolic acidosis as either a primary or secondary abnormality, you should calculate the anion gap to determine whether there is a HAGMA or a normal anion gap metabolic acidosis, sometimes called a NAGMA. To do this, subtract the chloride ion concentration and the bicarb ion concentration from the sodium ion concentration. These three electrolytes, along with the potassium ion, are the primary electrolytes involved in acid-base balance. Personally, I don't use the potassium ion in my calculation of the anion gap. However, some people do. Its effect is, by and large, very small and rarely makes a significant difference in the calculation. Once you calculate the anion gap, a number less than 12 is consistent with a NAGMA, whereas a number of 12 or more is consistent with a HAGMA. We've talked a little bit about the causes of HAGMA previously. Let's briefly discuss the causes of NAGMA now. In general, NAGMA occurs when the bicarb ion is lost more rapidly than hydrogen ions are lost. This occurs for a variety of reasons, including a rapidly rising chloride concentration, as may occur with aggressive normal saline administration, or other significant causes of NAGMA may include the GI tract, as may occur with severe intractable diarrhea, or through the kidney, as may occur in the various types of renal tubular acidosis. Okay, deep breath again. Whew, we've made it through that section. Now that we've talked about secondary abnormalities and anion gap calculations, it's time to move on to the next step. As is always true, if you don't feel entirely comfortable with these steps yet, please don't move forward. Go back, listen to my previous explanations, and try to get a better understanding of these concepts before you do move forward. There is one more item to consider with regard to anion gap calculations. In patients with significant hypoalbuminemia, the calculated anion gap should be corrected for the decreased albumin concentration using the formula listing on this slide. In general, the corrected anion gap may uncover HAGMA in patients that might otherwise be misdiagnosed with a NAGMA, and the wrong underlying problems may therefore be investigated. Okay, let's move on to some ABG examples to highlight this next step. In example number 8, can you determine the primary process, the secondary abnormality, and whether or not there is an anion gap? Remember, you might need to correct for hypoalbuminemia if it exists. I'll pause here. You take a second, run the numbers, and unpause me when you've got the right answer. Okay, this example is a primary respiratory acidosis. The pH is less than 7.40 and the PCO2 is significantly elevated. In calculating the compensation, it appears that there is a secondary metabolic acidosis. Using the anion gap calculation, this is a NAGMA. The albumin concentration is normal, and there is therefore no reason to correct for the hypoalbuminemia. This example, therefore, is respiratory acidosis with a secondary NAGMA. Let's now take a look at example number 9. Can you determine the primary abnormality, the secondary abnormality, and whether or not there is an anion gap? As is become usual, pause me here and work through the numbers, and then unpause when you've got the answer. This example is a primary metabolic acidosis with a respiratory acidosis. In evaluating the anion gap, there is a HAGMA. This is further validated when the anion gap is corrected for the measured hypoalbuminemia. This example, therefore, is a HAGMA with a secondary respiratory acidosis. All right, let's go back to our clinical case one more time. We have previously determined that this patient has a metabolic acidosis with a respiratory acidosis. Is this a HAGMA or a NAGMA? Okay, you've unpaused me, so I hope you're looking for the answer. And based on the corrected anion gap, this patient has a hagma with a concomitant respiratory acidosis. Okay, just one more step to go. As is always true, if you don't feel entirely comfortable yet with these steps, please don't move forward. Go back, listen to my previous explanations, and try to get a better understanding of these concepts before you do move forward. Some patients, believe it or not, may have 3 different acid-base abnormalities all existing at the same time. This is sometimes called the triple complex abnormalities. An evaluation for triple complex abnormalities should be performed for any patient with a primary or secondary hagma. In these patients, there is the potential for a concomitant nagma or a metabolic alkalosis. To evaluate for one of these triple complex abnormalities, you should calculate the so-called gap ratio. To do this, divide the difference of the corrected anion gap, N12, by the difference of 24 and the bicarb concentration, as shown in the formula on this slide. If the gap ratio is less than 1, there is a concomitant nagma. If the gap ratio is between 1 and 2, there is a simple hagma with no additional acid-base abnormality. If the gap ratio is greater than 2, there is a concomitant metabolic alkalosis. It should also be stated that if there is no secondary abnormality, there is still the possibility of having this triple complex abnormality. So you may have a high anion gap metabolic acidosis, a hagma, be appropriately compensated from a respiratory standpoint, but also have either a nagma or a metabolic alkalosis to go along with it. Our last example, ABG, example number 10. The pH is 7.25, the PCO2 is 40, the bicarb is 15. What are the primary and secondary abnormalities? Is there a triple base abnormality? And if so, what is it? As I've done, I will pause and come back to you when you've got the answer. Okay, complicated question, but this ABG demonstrates a primary hagma with a concurrent respiratory acidosis. The corrected anion gap is 40, and the calculated gap ratio is therefore greater than 2. This patient therefore also has a metabolic alkalosis. And it would be correct to say that the ABG demonstrates a hagma, a metabolic alkalosis, and a compensating respiratory acidosis. We are now at our last look at our clinical case. We have previously determined that the patient has a hagma with a respiratory acidosis. Are there any other acid-base abnormalities? Okay, I hope you've had the chance to look at and calculate what all has happened. In this example, our last of the examples for the day, the calculated anion gap is 17.5 when hypoalbuminemia is considered. Using the gap ratio formula, the gap ratio is less than 1, and the patient therefore appears to have an additional nagma. All told, in our clinical example of this patient with pneumonia in the setting of chronic COPD, he has a hagma with a nagma and a respiratory acidosis. Hey, awesome, you made it. We have now completed all the steps to complete a complex ABG interpretation. You can definitely take a deep breath again. All right, this slide is a basic review of all the steps we have developed, discussed, and practiced across both of these presentations. To do routine ABG analysis, first, determine whether it is an acidosis or an alkalosis, then determine the primary abnormality, then determine whether there is appropriate compensation of that primary abnormality, then, if compensation is not appropriate, determine what secondary abnormality does exist. Then, if appropriate, calculate the anion gap and determine whether hagma exists. If hypoalbuminemia is present, you will also need to correct the anion gap to account for the decreased serum albumin. Finally, if hagma exists as either a primary or a secondary abnormality, determine whether additional abnormalities, such as the triple complex abnormality, may exist. Awesome! Thank you so much for watching these presentations. I hope you've been able to learn something useful that you can apply to your patients today, tomorrow, and for a long time into the future. If you have any thoughts or comments, I can be reached at the email address on this slide. I hope you have a great day.